I am Valentin Fuster from New York, and it's a pleasure to be with you again. And this hour, we are going to try to summarize what happened in this meeting, the meeting of the American College of Cardiology that we have every year, and this time in Chicago. And actually, it's the 75th anniversary of the American College of Cardiology. So it's a big, big day. Well, thank you very much. As usual, I have 4 experts here, very well known in their own fields, who are going to help us to understand what appear to be interesting or important in this meeting in terms of the breaking trials. Well, let me introduce them. In my right, my friend Mario Gaudino, Professor Mario Gaudino, Professor of Cardiothoracic Surgery, Department of Cardiothoracic Surgery at Weill Cornell Medicine in New York. Here is another friend who worked together in JACC. Actually, is the head of JACC Electrophysiology, Professor Kalyanam Shivkumar. He is the head of electrophysiology at the University of California in Los Angeles. Thanks for coming, Chief.
Thank you.
And here in my left, Dr. Binita Shah, Director of Research, Interventional Cardiology, Associate Professor of Medicine at NYU School of Medicine in New York. Welcome.
Thank you for having me.
And then he's an old customer here, Dr. Clyde Yancy from Chicago, Vice Dean for Health Equity, Chief of Cardiology in the Department of Medicine at Northwestern University Medical Center in Chicago. Well, thank you very much. The question is what we are going to do. Not simple. There were 47 breaking trials presented in this meeting. We are going to try to at least present 8 of them, if we have time, and even we can have few words about others. 3 main subjects, I think, are of interest, at least to us, for the summary. One is about the structural heart disease. Very important in this meeting, isn't it? Mm-hmm. The second is thrombosis and antithrombotic therapy, also important. And the third is an interesting paper on hypertension, and much more. So let's go into business, a lot to do. And let me begin with the structural heart disease. And the first paper I would like to present is the ALIGN-AR trial. The name is TAVR with GINA valve for symptomatic aortic regurgitation in high surgical risk patients, presented by Dr. Raj Mekkar from Mount Sinai Heart Institute in Los Angeles. Aortic incompetence, I always thought TAVR will never work. Well, TAVR was actually tried for a while, and there were problems. Actually, 10% was the valve embolization, problems with valvular regurgitation. Very difficult to put a valve in the aortic position when there is no calcification. So this came the triology porcine pericardial valve, which is interesting, is a clip into the native leaflet. You have to explain to us exactly how it works. Well, this is there were preliminary work done on this. It was very supportive of a future, perhaps using this type of valve for aortic regurgitation. We are talking about the ALIGN-AR study design, multi-center, non-blinded, single-arm evaluation of patients with symptomatic plus or 3+ aortic regurgitation at high risk for surgery. And the question was a longitudinal study, TAVR with GINA valve triology system, that actually was looked at the primary safety endpoint at 30 days and then 1-year primary efficacy endpoint. Well, let's see what happened here. 500 patients were enrolled at 28 United States places. And here we have the interesting situation, which was, as we mentioned, there is a primary safety endpoint at 30 days. What they look at, all-cause mortality, stroke, measure bleeding, measure vascular complications, and then valve problems, new intervention needed, significant aortic regurgitation, etc. Well, let's start with this primary efficacy endpoint. The rate was 8.1% per year. And then we go into the hemodynamic valve performance, which is very interesting. Actually, it did very well. Mean gradient with this particular valve, 4.2 millimeters. 95% had almost no aortic regurgitation or just a tracing, compared with the original significant aortic regurgitation. Left ventricular remodeling was quite helpful. Functional class, we set class 3 plus or 4. Well, here we have 59% ended up with class 1 and 31% with class 2. So it really worked. Then we have the Kansas City overall score, 84% with a score of more than 60, very good. Then we have pacemaker, not so good. 23% require a pacemaker. Who actually require a pacemaker? Well, congestive heart failure patients, severe aortic regurgitation, a perimeter of equal more than 85 millimeters, and right bundle branch block. Well, just the conclusions, it looks good. Primary safety and efficacy outcomes, favorable risk-benefit profile, all good. Favorable valve performance, as we mentioned, low valve gradients, low rates of aortic regurgitation, as we already mentioned, good functional status, reverse remodeling, and implantation of a pacemaker in 23%. And this is leading now to the trial. This is a longitudinal study just using this valve, and now we have to compare with surgery, which is called the ARTIST trial, which is evolving at the present time. Well, my friend Mario, you think the interventionalists are taking over?
Well, I think this is a very different business compared to aortic stenosis. The annulus is larger, there is no calcium, the stroke volume is higher, so there are a lot of more technical challenge. I think those are very good results, but still initial result. The pacemaker rate is concerningly high. We have to look at long-term valve function, but definitely a very important step forward. This is a new valve that has an anchoring system that allow the valve to be deployed even in a situation when there is no calcium and the annulus is larger.
How is the anchoring, can you tell us?
Yeah, well, it's just 3 small hooks that essentially anchor the valve to the native leaflet. Yes. And that has been actually the key technical evolution that make this valve different compared to all the other devices. Yeah. And this is probably the step in the right direction. I think still some work to be done.
500 patients.
Yeah, it's
very good. What do you think, Binita?
I think this is definitely a step in the right direction. We have patients who don't really have an option for surgery at the moment who are suffering with aortic regurgitation, and we offer them the valves that are commercially available with the risks that are associated with it that are just unacceptably high. I mean, when we think about TAVR in AS, we started off with high pacemaker rates until we could optimize technique and so on and so forth. So I suspect the numbers will get better as time goes on, and at least for now, there may be a potential option for our patients who just don't have one.
Thank you. Quite exciting, isn't it?
It is exciting because remember, this is a volume load on the left ventricle. I think of valvular heart disease as ventricular conditions. The fact that we see such remarkable reverse remodeling and the improvement in KCCQ is non-trivial. That's a pretty important step forward. So if that's replicable in a major randomized trial with surgery, then we really have something important to bring to the equation.
Thank you. However, a lot of business for you, my friend. You see, pacemaker.
Yeah, so that is, of course, the type of business that electrophysiologists do not want to see. As Mario very astutely pointed out, the anatomy of the conduction system, especially the part where it goes through the membranous septum, is very structured, is between the non-coronary and the right coronary sinus. it's very fixed in anatomy. So I think if you correctly choose the patients as the study showed, be careful when patients already have a right bundle type pattern, and further collaboration here between the surgeons and the interventionalists is likely to improve the outcomes.
Well, in summary, a good study, isn't it?
Absolutely.
Yes.
A good study indeed, and certainly something that I still remember 2-3 years ago, we were quite skeptical, isn't it? But it's beautiful. Well, thank you. Let's move now. We continue with the structural heart disease. And the next paper is the paper from the low-risk trial investigators. And the title is 5-Year Outcomes After Transcatheter or Surgical Aortic Valve Replacement in Low-Risk Patients with Aortic Stenosis. This paper was presented by John Forrest from Yale University. Well, if I recall, there was a 2-year study, I think, and this is the same study with the supraannular self-expanding valve, the Evolut valve. In a 2 years of follow-up, what was already published, all-cause mortality or disabling stroke was very similar in the TAVR group than in the surgical group. This is a 2-year follow-up. Now it's basically a 5-year follow-up. What is happening? Well, they continue to be very equal. In fact, I'm going to be presenting the details. The investigators assigned low-risk patients with severe aortic stenosis to TAVR or surgery, as we mentioned. The primary endpoint was a composite of all-cause mortality or disabling stroke. Secondary endpoint included clinical, echocardiographic, and quality of the outcomes through 5 years. Number of patients, actually over 1,400. And women, 35%. And at 5 years, this is the study. 5 years, the Kaplan-Meier estimate for the primary endpoint was 15% TAVR, 16% in the surgical group. Cardiovascular mortality, 7.2%, TAVR, 9.3% in the surgical group, not significant difference. And again, over 5 years, reintervention, 3.3% versus 2.5%. Clinical valve thrombosis was less than 0.5% in both groups, and was a sustained improvement in quality of life in both groups. Let me read the conclusions. At 5 years, patients with severe aortic stenosis and low-risk surgery who were treated with either TAVR or surgery had comparable rates of all-cause mortality or disabling stroke. This midterm evaluation reinforces the position of TAVR as non-inferior to surgery in patients with severe aortic stenosis at low surgical risk. Clyde, this is very good, but are we moving into younger patients? So there's a little bit of a question here.
I agree with you, because we've always thought about the higher risk patient or the older patient. But now we have to expand that lens and think about younger patients. And this is where the shared decision-making conversation comes in, to say you can have surgery, maybe it's a more durable outcome, but you can also have TAVR, maybe with less morbidity, but the outcomes are not inferior, meaning they're similar. So I think it expands the conversation, Val.
Mario, what do you think about this presentation?
Look, the data are very solid, and I think for patients with a tricuspid aortic valve and aortic stenosis, in the first 5 years, there is no difference between surgery and TAVR. I also want to point out that people tend to think of TAVR versus SAVR as such as CABG versus PCI, but this is a wrong analogy, because in TAVR, the anatomic result is the same. You have a porcine bioprosthesis that is implanted above the aortic annulus, both transcatheter and surgery. So I do anticipate the outcome for TAVR and SAVR to be much more similar than CABG and PCI. Now, regarding the expansion to young patients, there is an important caveat, Dr. Fuster. I do believe there is a lot of work to be done to define the role of mechanical prosthesis in younger patients. This is a topic that has not been investigated in details. There is non-randomized data that suggests that young patients may benefit from mechanical aortic valve, so some work to be done.
I have a question for you.
Okay.
40-year-old,
Yes.
congenital bicuspid aortic stenosis, mechanical valve, TAVR, Ross procedure. What is your thinking?
So the Ross procedure, if it's in the right hands, you have to have a good surgeon who is experienced with the Ross procedure. Otherwise, mechanical valve is the right option, there, because these are young patients. We have to continue to think down the line with the redo valves. And now that we know that both options, at least in the relative short term, are good for 5 years, we need to get a little bit more nuanced in terms of which are the patients that have an edge with surgery, which are the patients that have an edge with TAVR. And that gets into comorbidities, that are not always captured in STS scores. That gets into also the annulus sizing, maybe women are a little bit smaller, but also the technique of the surgeon. The surgeon has to have that expertise, and we cannot lose that expertise. We certainly need it.
If I could weigh in, this is really an important question. I see these patients, and you think about subjecting someone to warfarin sodium chronically for a mechanical valve, and recognizing that for a bicuspid valve, we often need an aortic root replacement. So I'm still comfortable sending the patient to surgery for bioprosthesis with a root composite and following them out longitudinally. Some of the new bioprostheses, we probably have 10, 12-year expectancy, and we'll see how the technology evolves.
Yeah.
But Clyde, we also have new mechanical prostheses that do not require a lot of anticoagulation. They have never been tested in large randomized trials. But
so like I said, new data. Let's see what the data show. But if I make the decision now,
yeah.
Right.
So, Chip, you don't have a conflict of interest. As an electrophysiologist, what would you choose?
Well, I would very carefully evaluate the aorta. The decision has to be comprehensive.
Correct.
And I would still favor surgery because in a 40-year-old, you have to really think of the next 40 years of their life. So that's going to be the trade-off.
Thank you. Well, at least it was a good discussion, but at 5 years of follow-up, no difference. That's the bottom line.
great.
Now, the third paper also in structural heart disease, and I'm sorry I was involved on this, so I have to get out except asking questions. Dapagliflozin in patients undergoing transcatheter aortic valve implantation. This is a paper that was a combination from the National Center of Cardiovascular Investigation in Madrid, and actually a number of institutions, I think were 34 institutions in Spain. Well, here's the issue. First of all, patients who really went into trials with TAVR, they were not really in heart failure in the trials in general. And on the other hand, there is a high rate of decompensation in patients with aortic stenosis anyway after intervention. At the same time, SGLT2 inhibitors, nobody thought about it in patients undergoing TAVR. And most of the patients who were over age of 80 were not entered into TAVR studies. Well, all of this together decided, let's move on and try to use SGLT2 inhibitors on patients who are in trouble. I mean, I have to describe who these patients are. This was conducted independent, pragmatic, prospective, randomized, open-blinded endpoint trial in Spain to evaluate the efficacy of dapagliflozin 10 milligrams daily compared to standard of care in patients with aortic stenosis undergoing TAVR. And now comes the critical issue. They had prior episode of heart failure and renal insufficiency or diabetes or left ventricular systolic dysfunction. So these were troubled patients. The primary outcome was a composite of all-cause death, worsening heart failure. How do we define it? Define as hospitalization or urgent visit from the time of hospital discharge at 1 year. The number of patients was actually a larger study, was over 1,200 from 39 centers. The primary, let me say more about, actually, the average age was 82 years. This is important. And 50% were women. Now, these are the results, actually. The group on dapagliflozin, which were half of them, 15% endpoints, 20% for the group that had a standard care, with a hazard ratio of 0.72 and a p-value of 0.01. All-cause death, 7.8% versus 9.1%, with a hazard ratio of 0.87. Worsening heart failure, 9.4% versus 14%. And then there were some infections, genitourinary infections. It was about 2%, and hypotension, very few patients. So, in conclusion, we were somewhat surprised, actually. The study worked. Among older adults with aortic stenosis undergoing TAVI and at high risk for future heart failure events, dapagliflozin resulted in a significantly lower incidence of all-cause death or worsening heart failure. This is published today in the New England Journal, I think. Binita, how you react to that?
I think it's an important study, and it gets to the point that a lot of our patients with aortic stenosis have comorbidities that relate to heart failure, that the heart failure is not necessarily all due to the AS as well. There's a portion of our patients who have undiagnosed amyloid. There are other contributors that come into play. Usually when we see AS and ejection fraction, we think 1-to-1, but if anything, I see our patients undergoing TAVI, and some portion of them are still having heart failure symptoms because their contributing factors to their heart failure was not just the valve.
Okay, thank you. Let's ask the expert in heart failure. Clyde.
So this is a good morning looking at cardiovascular physiology. We started our conversation about a volume-loaded ventricle. Now we have an afterload mismatch ventricle. We have to understand that there are changes in the ventricle over time that set up this episode of heart failure that's concerning. On top of that, we have CKD and diabetes. This is a very important study because it reminds us to think about this risk for heart failure even after TAVR. We can't presume that we've ameliorated that risk altogether. And the idea of preempting this with an effective regimen with a large evidence base of efficacy, this is brilliant work. And I think this changes practice today.
Thank you. SGLT2 inhibitors are getting into your business too? Because they are getting everywhere.
They are. You know, when you see studies like this, you think, should everything be in the water supply? But again, the accumulating data is extremely reassuring. And for me, as a physician scientist, I continue to be amazed by how effective these medications are. And to follow up on Dr. Yancy's point, it's almost preemptive. So in other words, it's the right treatment for the right patient, and sort of looks at it comprehensively. And again, we shouldn't fall into the trap of this 1:1. And that is the common mistake that happens in practice, where patients don't look at the big picture. So having a team-based approach. So we were very excited reading this paper, Dr. Fuster.
Thank you. Mario, last word.
Well, I think that may very well apply also to surgical patients. I mean, the idea that a single intervention is able to solve all the issue is wrong, and I think that just show us once again how post-intervention therapy is critical for success. So, very important paper.
Thank you. Okay, we have a fourth paper, number 4 or so. Yeah. On intervention, well, what a day. We are moving to the tricuspid valve, at least. Anyway, the TRILUMINATE, the 2-year follow-up, again, this is an interesting, we have 1-year follow-up, now it's 2 years. Titled 2-year outcome of transcatheter H2H repair for severe tricuspid regurgitation, the TRILUMINATE Pivotal randomized controlled trial. Well, the 1 year, at least the question was, we look at mortality, hospitalization. This is in the endpoints, were very hard endpoints at 1 year. And the other were all functional, how the patient feels and so forth. And if I recall, the primary endpoint didn't work well. It's not correct?
That's right.
Okay. So let's what happened at year number 2. Actually, I think this endpoint, hard endpoint of mortality and hospitalization also happened in the TRISCEND-2 trial, as indeed with valve replacement rather than in the tricuspid position. Well, let's see what happened in the 2-year follow-up. This is the story. The number of patients, 572, with severe symptomatic tricuspid regurgitation. They were randomized to either tricuspid H2H plus medical therapy, the device group, or patients with only medical therapy, the control group. As I mentioned, 2 years of specified endpoints, the ones we mentioned at the beginning, certainly all-cause mortality, recurrence of heart failure hospitalization, and actually need for valve replacement or surgical approach to the valve. The annualized rate of recurrent heart failure hospitalization through 2 years was actually significantly lower. Let me, before I get into the results, I read this paper many times in trying to figure out all the details. And I will say to you, it has 1 plus, it has 2 plus minuses, and has a minus. Because it's complex when you start looking at all the possibilities and so forth. Let me go for the plus first. The annualized rate of recurrent heart failure hospitalization, a good endpoint, through 2 years was significantly lower with the tricuspid H2H compared to control, 0.19 versus 0.26 events patient year, with a p-value of 0.02. This is an advance to the first study that was 1 year. Then comes 1 plus minus that is not easy to understand. Freedom from all the following: all-cause mortality, tricuspid valve surgery, tricuspid valve intervention through 2 years was significantly higher with tricuspid H2H compared to control, 77% versus 29%. Well, I don't know really what it means, because in fact, with all these variables, this was driven by tricuspid valve intervention in control patients crossing over. I didn't reach that stage of sophistication, okay? I'm just, so
just the
I put
crossover.
plus minus because I don't understand it. Then was a minus, all-cause mortality. Well, it's not a minus, it didn't work, we're both the same, all-cause mortality. And another plus minus is moderate or less tricuspid regurgitation was present in 84% at 2 years. This is not bad, actually. So let's summarize. At 2 years of follow-up, end-to-end approach to the tricuspid valve appears to be safe, and significant reduction of tricuspid regurgitation takes place. Most importantly is the decrease in rates of heart failure hospitalization compared to medical therapy alone. Well, Mario, what do you think about this tricuspid valve?
Look, this is great because those are the patients that the surgeon does not want to see. You know that in the STS database, the single operation with the highest operative mortality is isolated tricuspid regurgitation. So those are very sick patients, who do not tolerate surgery well. And so I think transcatheter intervention are definitely the way to go. I read this study as a positive study. I think the rate of readmission for heart failure was clearly lower. There was a benefit in terms of both the severity of TR and also the quality of life. They did allow crossover from control to intervention after 1 year. That's why the study seemed a little bit messy. But I think overall it's a very positive study, and I think this is definitely the way to go for tricuspid.
Thank you. Binita, do you think the future is going to be H2H, or is going to be valve replacement, or a combination? What is your feeling in the tricuspid position?
Yeah, it's a great question. You know, at least valve replacement allows for future pacemaker setup and ICD setup as needed versus the clip or the repair version. But I think we still need more data in this area. It's certainly promising to have heart failure reduction The 1-year results weren't as exciting, and at least we're seeing some hard endpoint reduction here. So I think we'll just have to see where the studies take us, where the innovation takes us.
Clyde, these patients are actually very sick, isn't
Exactly.
it? I mean,
We have to look at this as an evolving paradigm because this is not an isolated valvular disease. It's almost always associated with hepatic disease and with chronic insufficiency and renal disease. So I'm not certain the cardiologists are any more enthusiastic about dealing with this than surgeons are because it's not just one thing.
Right.
We'll take care of everyone that comes to see us, but we have to realize for this particular patient with severe TR, despite the intervention, we still have work to do.
Absolutely.
Hip, let me ask you a question. You know, I have a patient, actually, I had a patient recently, huge tricuspid regurgitation with the wire of the pacemaker making the problem. Do you think, what do? You take the wire out and then you do the H2H? How do you manage?
This is a great question. Patients who actually have a CIED lead across the tricuspid valve require very comprehensive imaging. And that we've become very sophisticated in understanding how it works, whether it's adherent to the valve structures, the subvalvular structures, whether it's plastered to the papillary muscles. The papillary muscles of the tricuspid valve are anatomically very beautiful. They are variable, and the tricuspid valve is not always tricuspid either. It could have other four cusps. All these variables have to be taken into account. Sometimes you can do a lead extraction depending on how long the lead has been in. And there are many other options. We could now actually pace via the coronary venous system. So I think the comprehensive evaluation of the patient becomes important if you can take away the underlying problem. The second set of data is even if the presence of a lead sometimes, some of these appropriate cases can be referred to the interventionalist for a transcatheter-based repair. Again, case by case. There was a recent paper that was published in JACC Electrophysiology, and in fact, in January 28th issue of main JACC, the entire issue was devoted to the tricuspid valve. So I think some of these issues have been looked at a little more in detail in that paper.
This is such an important issue because sometimes by TEE, we see that the leaflet is entrapped. Sometimes it's even penetrated. It does make you wonder if the leadless pacers, as the technology involves, will help us. And thinking about the subcutaneous epicardial leads, in my world, particularly for ICDs, but we have to begin to think about, is there a better way, a different way?
Absolutely. This is where innovations are needed. I'd also like to put in a plug for the fact that the tricuspid valve is anatomically very different from the mitral. It does not have a complete annulus. Electrophysiologists work in that neighborhood a lot for even things like flutter ablation. And sometimes we often wonder what is the long-term prognosis of ablating near these valve structures. I think our sophistication of cardiac imaging and understanding cardiac anatomy is going to be important.
I really admire what you have done, because here we have an electrophysiologist that has the best pictures of anatomy of the heart I have ever seen. Mm-hmm. And in the JACC, every week, there is one of the aspects of the anatomy of the heart being presented. So you have to be congratulated. It's beautiful.
Thank you so much, Dr. Fuster. That is, you're referring to the Amara Yad project, which we did as to honor the victims of the Holocaust. And that is something really keeping with the spirit of our profession. And anatomy is incredibly important. It's not going to change. Our understanding of that improves. And you just heard among all the speakers over here that, we are all students. I think it's, and thank you so much for your kind words of encouragement for that project.
Thank you. All right. Well, enough for a structure. You should go.
No, we want that.
Your business is over.
Well, what this emphasized to me is how important it is to have everyone in the room when we discuss these patients, because they certainly are very complex.
Well, thank you very much. Let's move now into the thrombotic field and antithrombotic therapy. The first paper we are going to present, I think, is interesting. Certainly has been a question to all of us. This is the RIVAWAR trial, efficacy of rivaroxaban versus warfarin in patients with acute left ventricular thrombus following myocardial infarction, an open-label randomized controlled trial. I think the question has been so many years what to use, what not to use. And let me give few figures just to remind us of the problem. Meta-analysis, actually recent meta-analysis of left ventricular thrombus rates have been about 2.7% to 6.3% in patients with a STEMI. Now, if the patient has an anterior STEMI, 9.1% versus 12%. This is, again, left ventricular thrombus. And if the patient has anterior myocardial infarction, left ventricular dysfunction with ejection fraction of less than 50%, could be 19% the presence or the incidence of left ventricular thrombus. If a thrombus is found, today, even with PCR, using intervention at the time of infarction, the embolic rate, if there is a thrombus, is about 15%. So it's a problem. In fact, it's interesting because with PCI following MI, we thought, well, the issue of left ventricular thrombus is not. In fact, it's still a problem. Well, the question is what to use, and over the years, warfarin has been the drug of use, and there are a number of studies with warfarin and actually NOAC, but they were very heterogeneous studies, longitudinal studies, and so forth, but not the study that is presented today, which is probably the best in the field. And let's go into the details. Now, the investigators conducted, in a RIT, an open-label, non-inferiority randomized controlled trial enrolling patients with acute left ventricular thrombus diagnosed during the initial hospitalization for acute myocardial infarction. Participants were randomized in a 2-to-1 ratio to receive either rivaroxaban 20 milligrams daily or warfarin with a target INR of 2 to 3 for 3 months. The primary endpoint was left ventricular thrombus resolution that was assessed by echocardiography at 1 and at 3 months. The number of patients was 261, not easy to find with all these left ventricular thrombus. They were randomized, as I mentioned, actually 171 were on rivaroxaban and 90 were treated with warfarin. 77% male, mean age 54 years. Most of the patients had STEMI, and most had underwent primary PCI. And severe left ventricular dysfunction was high, actually 93%, with an ejection fraction of less than 35%. So this is a sick group. These are the results. Left ventricular thrombus resolution at 1 month was higher in the rivaroxaban group, 20%, versus 8% in the group treated with warfarin. But at 3 months was similar, but very good, 95% resolution versus 96%. Then the cumulative all-cause mortality was comparable, 3.5% versus 3.3%. Measure bleeding, 2.3% versus 1.1%. Ischemic stroke, 3% versus 1.1%. So it's an interesting study. I like to read the conclusions as published. In patients with post-MI left ventricular thrombus, rivaroxaban demonstrated similar efficacy and safety to warfarin in resolving left ventricular thrombus at 3 months of follow-up, with complete resolution of left ventricular thrombus in more than 95% in both groups, without evidence of excess harm in terms of mortality, ischemic stroke, or measure bleeding. These findings support rivaroxaban as a viable alternative to warfarin, offering predictable dosing and eliminating the need for routine INR monitoring. Clyde, how do you react to this paper?
Have several reactions. The first, I want to pay homage to your early work evaluating warfarin sodium in the setting of a dilated ventricle. You were one of the first to bring that hypothesis to the table, so thank you for starting that conversation. But I think what makes this very important is that it elevates the concern that we need to still have about mechanical complications of acute myocardial infarction. We've gotten so accustomed to great outcomes, but in the pre-PCI, pre-lytic area, we were dealing with either ventricular septal defects, mitral valve disturbances, left ventricular aneurysms with thrombus, with embolic complications. I think the most important thing is that it re-elevates our awareness that these things happen. I'm pleased to see that regardless of the anticoagulation regimen, you can resolve it and have very good outcomes. And I'm pleased to see that rivaroxaban is an alternative. But I think it's most important that we reacquaint the community at large with this risk of mechanical complications after myocardial infarction.
Good point. Binita?
Well, I echo that point. I say we've gotten very good with door-to-balloon times coming in and such, but ischemic time is still a problem. Patients are still at home not recognizing they're having a heart attack. Urban planning is important to be able to get patients to the hospital quickly. And so these complications do still exist, and we need to know how to manage them.
Sheep?
So it's an incredibly important study, and of course it says why you have to look at the echocardiogram of a patient like this very closely. Obviously, electrophysiologists sometimes are called to see VT storm in this condition, but we look carefully in the sinus rhythm imaging to see if there's already smoke in the ventricle. To Dr. Yancy's point, look at the whole patient and look at the whole heart, and I think this is practice reinforcing, I would say.
Good point. Mario?
Well, just to point out that the actual incidence of thrombus may be actually higher. They use echocardiography. They didn't use MRI. You know that MRI is more sensitive, so the incidence could have been even higher. And I think, if you have an alternative to warfarin, you don't have to check your INR, it's faster to act. I think it's probably clinically relevant.
One of the things we are working on now is to distinguish a fresh clot versus an organized clot through positron emission tomography. I think the technology will be available within a year because we face this with left atrial thrombi on atrial fibrillation. You go to Cardiovert, you don't have any idea what that means, isn't it? So I think this is coming. But the issue of thrombosis in the chambers is now beginning to come back again, I think. Thank you. All right, so still on thrombosis, antithrombotic therapy. Yeah, the next study I would like to review is the SMART Choice 3 study, just published in The Lancet. And the title is Efficacy and Safety of Clopidogrel versus Aspirin Monotherapy in Patients at High Risk of Subsequent Cardiovascular Event After Percutaneous Coronary Intervention, a randomized open-label multi-center trial. Well, let's go back to a study that actually I reviewed very carefully, and this is about, maybe it's a year ago. It's the so-called host exam study. I don't know if you remember. The question is, when the patient gets stabilized after a year of a PCI, the question is to use monotherapy, and I think classically we have used aspirin. But somebody came with the idea that perhaps clopidogrel would do better if the patient is not a bleeder. And this is what the study, the host exam study, came up with, saying that certainly clopidogrel appeared to be a little bit better than aspirin in the stable patient with coronary artery disease after 1 year of PCI. What is different in this study? In this study, they look at exactly the same question, but in a very high-risk patients. And therefore, you might expect that clopidogrel perhaps is even much better than what was presented before. Well, with this introduction, let me now move into the study. This is a multi-center, open-label, randomized trial patients aged 19 years or older at high risk of recurrent ischemic events. Let me tell you how they describe the high risk. Previous myocardial infarction at any time before enrollment, medication-treated diabetes, or complex coronary lesions. These patients completed a standard duration of dual antiplatelet therapy after PCI, and they were randomized 1-to-1 to receive clopidogrel, 75 milligrams once daily, or aspirin, 100 milligrams once daily. The study was done in South Korea at 26 sites. The primary endpoint was the cumulative incidence of composite of death from any cause, myocardial infarction, or a stroke. So a very strong endpoint, actually, a very hard endpoint. And this was an intention to treat population. Adverse events were captured as part of the secondary endpoint. Now, the patient between August of 2020 and July of 2023, we are talking about more than 5,000 patients were enrolled in the study. About half with clopidogrel, half with aspirin. As I mentioned, median time between PCI and randomization was 17 months, so certainly after a year. And during a median follow-up of 2.3 years, the primary endpoint was 4.4% for the clopidogrel group versus 6.6% for the aspirin group, a hazard ratio of 0.71 and a p-value which was significant. Then they look at death by just death from any cause, 2.4% in favor of clopidogrel versus 4% aspirin. Then they look at myocardial infarction, 1% versus 2.2%. And then they look at the stroke and was the same. So in conclusion, as I read, among patients who were at high risk of recurrent ischemic events and who completed the standard duration of dual antiplatelet therapy following PCI, clopidogrel monotherapy compared with aspirin monotherapy significantly reduced the cumulative incidence of a composite death from any cause, myocardial infarction, and stroke without an apparent increase in the risk of bleeding, which I didn't mention. So, Binita, what do you think about a study like this? After a year, we usually give aspirin. Would you begin to give clopidogrel if the patient's at high risk?
Possibly. I still worry about the patients that are not within my system, in my clinic, that I'm seeing often because, you know, non-cardiac surgery comes along. They need their appendix out, they have, you know, abdomen, ulcer, bursts, whatever it may be. Non-cardiac surgeons are not operating on Plavix, and it's very important then at that point to change the antiplatelet during the surgery so that the patient isn't on anything. And so if it's my patient that I'm following or within a system that I trust, then I feel very comfortable switching to clopidogrel monotherapy, especially with the ischemic benefit. But if it's someone I'm never going to see again for whatever reason, I do worry about the long-term risk.
Chip, I give you, I give you a patient after a year of PCI, high risk for bleeding, and I give you another patient, high risk for clotting, ischemia. What would you use? Two different patients. One is a bleeder, and the other is a clotter.
So that's almost a trick question. I think you are probably better off having what is the best outcome for the patient. I'd rather deal with the problems of bleeding, because if I have to do an intervention or work with an interventionalist, there are ways of overcoming that, whereas a clot is a much worse outcome for a patient.
You would give aspirin in the bleeder and clopidogrel to the clotter.
Yes, that would be ideal,
yeah.
But we don't have a good way to phenotype them ahead of time.
Understand. Clyde, what would you do?
I think there's another issue on the table. This is interesting, but this isn't practice changing. I need to see this in a larger population. I need to see it replicated in the US. And we need to remember that it's not just the lesion upon which there was an intervention, it's the totality of atherosclerosis. And we have a lot more information about aspirin as an appropriate secondary prevention intervention than we have for clopidogrel in that setting. So I would need to see more data. I would stay with the aspirin. Bleeding or clotting, I would stay with the aspirin.
Yeah, you make a very important point, though, for the doctors. You have to see the overall of the patient. The question I ask is very specific, but it's not the right question. I think, no, but this is true.
Yes.
We have to have a general view of the patient. What do you think, Mario?
Well, I apply this to my field. I think a lot of surgical patients would fall in the category of high risk for recurring events. And I don't have a clear answer, but I just want to say a lot of work needs to be done in CABG patient, in patient who undergo surgical revascularization, to identify the best antiplatelet strategy. We are working on that. We are beyond compared to PCI. There have been less